The next piece of the format is kind of the feedback side. What questions do you have? I mean, the benefit I see to a meeting like this is we all know each other. You know, I mean, we've probably been treated or served by the folks sitting up here in front. We know what we need, we know what we want, we know where we're trying to go. So as you as a community look at how are you being treated by the healthcare system and what questions do you have, I guess that's the piece I'd like to see if we could fill in here from you folks. So anybody want to go first out of the chute here? Go ahead, sir.
This is sort of a general question for all of you, but perhaps for the insurance man most of all. One of the choices I see the country faces, not in the county necessarily, is do we want to require everyone to buy private insurance, subsidizing some of those who can't afford it, which would be one way of solving the problem you mentioned of people just getting insurance so that they can get immediate help and therefore raising everyone's premium in a small group. As I understand it, the reason that many in the insurance lobby, as you call it, want some of the present bills that are now going is because they're going to get what they really want, which is more people buying their insurance and having to buy their insurance. And another issue which is related to this, I don't think there'll be any real control of the prices they can charge for that, which might not solve the problem of the government having more, with the subsidies they have to give low-income people to pay for that, unless you have some kind of control, but that's another issue. The other alternative, which I would suggest, I support, by the way, single payer, which they have in Canada or Britain or most other industrialized countries, where the problem is also solved, and several problems that you guys have brought up here are solved, because you do get lower drug prices because the governments there can negotiate for prices which the drug companies then have to provide them. They have to pay, they have to take whatever the government offers them, plus the same way the doctors and hospitals, because the budget, the government budget sets how much is going to be spent, and they do not allow, it's something like Medicare that we have now, except that as you know that Medicare can charge above that for private patients, and so what I'm trying to say is there are different ways. There's one way to do it, which is require everyone to have private insurance, which I think would, not be the best way, but it would solve some of these problems. The other way is simply to have a full government program and still let people choose their doctor, their hospital, and so on. Although hospitals, as you know, in some places, they are employees of the government, or some private.
Can we kind of just leave it at those two questions and the thoughts on the current healthcare providers from the insurance point of view, and then perhaps a thought or two maybe across the board on that, and then single payer?
The question I've asked anybody is how many countries that have 350 million people have nationalized health care? Huh? And we also look at, we have a very diverse community. I mean, not only here in Iowa, but throughout the United States. What do you have in Sweden? 95% Swedes. That's it. Okay? It's a homogeneous group. We are not a homogeneous group. So when we look at how many other countries of 350 million people, there aren't any. So talking about comparing us to Spain, England, or Canada, I don't think that's good. The other thing is on nationalized health care, you've totally eliminated, which is one of the things that has one of our highest, does increase our cost of health care. You have no litigation. You have no litigation with national health care. That would take away that from our own citizens. The thing as far as on buying the drugs, I don't buy the brands. They tell you this is what you're going to get. And if you go up to Canada and talk to the Canadians, as I do safaris. I go up there to do research on what they.
I'm doing the same thing up there. Right?
Yes, and Dave does too, he's trying to find a quarry. But we go up there for business reasons. Not all of them are all that happy, especially the small business owners. They're paying a tremendous amount of taxes. Because somebody's got to pay for it, it's not free. It's not free up there, and they really do suffer, plus the waiting time. It's interesting that 25% of all the patients in the Detroit hospitals are Canadians. Odd.
Mike, thoughts from the hospital point of view?
Sir, are you from Canada?
No, I'm afraid not.
I thought maybe you were. I thought maybe, because my concerns about the Canadian healthcare system and the Great Britain's healthcare system is based on some anecdotes. I attended a conference a few years ago. It was this time of year, and it just so happened there was a Canadian orthopedic surgeon who was sitting at my table. And we just started talking and chatting, and I said, "What are you doing down here if you're from Canada?" He says, "Well," he says, "I've met my quota of surgeries that I can do for the year." He says, "So for the remaining three and a half months of the year, I come down here, I practice, I do surgery, and then I go back to Canada." And I said, "Well, what do you think the difference is?" I says, "Well," he says, "it's nice in Canada where, as Bob said, he says, I can't be sued. You can't sue cardiology in Canada under the plan." He says, "Down here it costs a lot for malpractice insurance." He said, "But there's pluses and minuses. I really don't like the idea of having to tell my patients I can't see them again until next year." From England's perspective, we had a surgeon once upon a time, where I'm sure many of you know, who was from England. And his mother passed away. I believe she was 78 at the time when she died. She died from something that over here is relatively simple, a simple surgery. She had an abdominal blockage. And they wouldn't do the surgery for her over there. And he said, "Boy, I could have brought her over here, but I couldn't bring her over here because I couldn't move her. And I couldn't go over there because I didn't have privilege to do the surgery." That, in my mind, is tragic. And when you look at what's being proposed, and I don't want to talk about 3,200, but they are talking about taking $500 billion, $500 billion out of the Medicare system. So what does that mean? That means that providers are going to be paid a lot less to do what they're currently doing right now. So if, I used this example the other day at Kiwanis, where Barry, for example, needs a $1,000 MRI, and it costs us $1,000 to give it, we'll probably give it to Barry. We like Barry, throw his money out, yeah, sure, we'll do it fine. But if I'm only going to get paid $750 to do it, let's face it, I've got to think twice about that. I've got to talk to the doctor and say, you know, we can't continue to offer these services and lose $250 every time we offer it. So ratcheting down what the government's willing to pay under a Medicare type system, seeing what's happened in Canada and England, I do think it would lead to rationing. And it's not going to be for me because I'm still relatively young, but it is going to be for those older folks in the Medicare system. That's my feeling, that's it.
Dr. Meeker?
Could I have a rebuttal before you continue on that? It seems to me that what the administration is proposing is to get rid of Medicare Advantage. They're not talking about Medicare necessarily itself, that is the traditional Medicare. And I don't think Medicare Advantage, which is giving subsidies to the private insurance companies and trying to lure people away from traditional Medicare into private insurance, is a good idea. I don't think it ever was. And so I don't think you can say that all of Medicare is going to be cut. We haven't seen that yet, and I wouldn't think that would be done. You know, so I don't think you should blame, when Obama talks about these cuts, I think that's what he's talking about. And he's also talking about the supposed, you know, assurance that the drug companies have given him that they're going to solve the donut hole problem for people on Part D to save some of the money that the government and also individuals are having to pay now. So that's part of his savings. But I don't think, you know, that this is